medicines. They may not be very compliant. They may be inundated with alternate messages saying that the medicines are harmful, particularly in this social media and WhatsApp era. And then there is fragmented healthcare and lack of referral linkages. So what are the potential solutions that we have worked on? And I'm going to give some examples. The first is, can we use polypill or a fixed dose combination to improve adherence? The second is quality improvement programs, digital health, and task sharing. I won't talk about this in great detail because I see my friend Lijing going to give that talk. I'm going to touch a little bit on cardiac rehabilitation and show how alternate tools to cardiac rehabilitation, such as yoga in India or Tai Chi in China, could be of help. Air pollution is an important aspect, but I'm not going to talk about it due to paucity of time. There can be personal and system level interventions. Patient engagement to improve their own self-care is an important area. Again, I'm going to touch very briefly on that when I talk about improving access to telemedicine and other solutions. So we did this trial way back, 10 years back, where we looked at the effect of FTC on adherence of these factors in patients in post-MI situations or patients with high risk of coronary artery disease, high-risk coronary artery disease. At the end of the study, the adherence in the FDC group was 33% higher as compared to the usual care group, and there were some reductions in systolic blood pressure and LDL cholesterol. But subsequent to that, there have been other studies from Spain, from US, from Australia, and many other parts of the world showing that it's indeed very useful in secondary prevention as well as primary prevention. But it's not panned out the way we wanted it to happen, because we required that there should be a buy-in of the medical professionals. And one of the major reasons why they are not very comfortable is they feel that their autonomy is eroded and they would like to prescribe individual drugs with dose titration. In terms of patients, some evaluation has been done in terms of using non-physician health workers to follow up and provide treatment to these patients, but acceptance by patients is poor. And there are other factors too. The biggest hurdle is the pharmaceutical industries, because they feel that their profits will go down if they're going to go through the generic route and manufacture these fixed dose combinations. And there was no buy-in from the governments, and even international agencies like WHO had not put them in the essential drugs list till very recently. Only this year it has been included in the essential drug list, and therefore I think that there will be more interest in these drugs. Then the second area that I think we should look at is improvement in quality of care, which includes many of these aspects, and we have worked on many of these aspects. That includes developing electronic decision support system, integrated care, where the whole team works in terms of providing secondary prevention, quality improvement program. I'll talk briefly about this, called the AHS Quick Trial, cardiac rehabilitation, team-based care, and management principles. Many of the management principles that are used in manufacturing can actually be brought into the healthcare to improve outcomes of patients, but that's for another day because of the paucity of time. So I'm going to talk briefly about the quality improvement toolkit on acute myocardial infarction called the ACS cluster randomized trial, which was a step-wedge trial. It's a special type of cluster randomized trial where we randomize the time points at which the patients enter into the study. So the evidence before this was the randomized trials of quality improvement interventions in Brazil and China had demonstrated improvements in the process measures, but had not powered to detect differences in clinical outcomes. And our team had previously demonstrated several areas of improvement in acute coronary syndrome care in India based on data from close to 25,000 participants enrolled in the Kerala ACS registry. The framework included, when we look at the PCOTS framework, the participants were patients with acute myocardial infarction admitted to participating hospital. The intervention was multifaceted, adapted quality improvement toolkit based on the American Heart Association's Get With The guidelines. The comparator was the usual care, and the outcome, we were very ambitious in terms of the outcomes. So we included primary outcome as death, reinfarction, stroke, and major bleeding. And secondary outcome included individual MACE components quality of life, microeconomic cost, process evaluation, and the time course was 30 days, and the setting was in Kerala, India. So we conducted a cluster randomized stepwise clinical trial in 63 hospitals, and the study period was between November 2014 to November 2016, and we recruited 21,374 patients. The primary outcome was a 30-day major adverse cardiovascular event, and the secondary outcomes were health-related quality of life and microeconomic costs. The ACS Quick Toolkit components included audit feedback reporting mechanism to inform monthly quality improvement meetings for plan, do, study act cycle, which is used in manufacturing industries. We also looked at standardized admission and discharge order sets and clinical pathways, and we provided patient education materials, diet, activity, and tobacco cessation adapted to the context of Kerala. And the code and rapid response team training assistance was provided. The hospitals included both private and public sector. In fact, a large majority of the hospitals came from private sector, followed by the government sector and the semi-government sectors. The step-wise design is given here, which is the consort flow diagram, where everybody is recruited initially, and then the intervention is introduced in 1/4 of these hospitals, and it progressively till we reach the final 25%. So essentially, everybody receives the intervention. Some people receive interventions from the beginning till the end. Some people receive interventions over a 3-month period or so. So we analyzed based on this recruitment into control and intervention group. There was very minimal loss to follow-up, and there were no differences in baseline characteristics. So when we looked at the MAZE, 30-day MAZE, the unadjusted OR showed an 18% reduction in terms of MAZE, a 24% reduction in terms of death, and there was no difference in the reinfarction rate, no difference in the stroke rate, and no difference in the bleeding. But when we did a multiple logistic regression, because there were some changes that happened temporal changes that happened within the community in the state of Kerala, which is in the south of India, and we found that there was no difference. But a post-hoc analysis showed there was a 16% decline if we added prevention of heart failure, shock, and cardiac arrest. So there is some evidence that it works. But what we showed was that the process of care definitely improves. Probably in the setting of Kerala, where the treatment was very high, I think the intervention was not as effective, but it could be still very effective in settings where such high-level care is not provided. The second thing which I wanted to talk about is cardiac rehabilitation. We all know it's a class 1 indication, but the big problem is cardiac rehabilitation is expensive, it's limited, it's non-existent in many parts of the world, and there is a high unmet need. The reason why we chose yoga as a replacement for cardiac rehabilitation is multifold. What we plan to do in cardiac rehabilitation is we want patients to be physically fit. We provide them exercise training. We want them to have some lifestyle changes in terms of smoking cessation, healthy diet, so provide nutritional counseling and promote other healthy behaviors. In terms of stress reduction, there will be counseling, medication for depression, and cardiac rehabilitation really works according to several meta-analysis. Now, what about yoga? Yoga, we believe, can do all of these things: physical fitness through yogic postures, lifestyle changes through the self-restraint, which is part of the yoga package, and stress reduction through breath control and meditation. The only thing that we needed was to show that it is safe and that it can work. So we did a large study to compare the effectiveness of yoga-based cardiac rehabilitation with enhanced standard care in post-myocardial infarction patients in cardiac morbidity and mortality and quality of life. And the primary outcomes were time to occurrence of first cardiac event and quality of life at 12 weeks. And there were a range of secondary outcomes. There were 24 sites in India, and we used a probe design, which is prospective randomized open label blinded endpoint assessment. And the trial duration was for 50 months, and close to 4,000 patients were recruited. It had 80% power to detect 20% reduction in cardiovascular events and 99% power to detect difference in quality of life. And we performed both the ITT and the per protocol analysis. So we recruited patients within 14 days of acute myocardial infarction. and were willing to and able to attend complete cardiac rehabilitation program. The intervention comprises of first we conducted a literature review and refined through an internal stakeholder group and external panel of internal experts and piloted with yoga teachers and post-MI patients. The structure consisted of yoga care sessions aligned to the cardiac rehabilitation phases, which includes in the first week education on lifestyle, in week 3 meditation and breathing, and week 5 to 7 full yoga training session twice per week, and weeks 8 to 13 full yoga training session once per week, and after the 14th week, self-practice at home. The personnel included trained yoga instructor to deliver pre-selected yoga practice and health education. We had 3 health rejuvenating exercises, 15 postures and 5 breathing techniques and 5 meditative techniques. To the control group, we provided what we called as enhanced standard care that included 3 sessions of educational information before discharge from the hospital, and subsequently at weeks 5 and 12, we provided printed leaflet delivered by nurse and another member of cardiac care, either individually or in groups, to avoid contamination. In terms of primary outcome, there was a 9% reduction, but it was not statistically significant because it was underpowered. We expected close to 15% MACE, but what we got ultimately was half of that 7.3%. And this was across the board. And there were numerically fewer outcomes in the yoga care, as I said, but not statistically significant. In terms of the lifestyle quality of life, the mean EQ5D was much better in the yoga care group as compared to the usual care group. And it's remained significant after adjusting for baseline covariates. There was, in addition, early return to pre-infarct activity. So to summarize, it was a successful collaboration of 24 hospitals in India. It was presented at the late-breaking presentation at AHA, and it was driven by clinical endpoints, but it was underpowered. So we continued the study further, but we still had lower event rates, and we did not have enough evidence to show that it's that it can reduce MACE. It did reduce MACE, but after adjustment for several covariates, it was negative. But it improved quality of life. It can be a good starting point for cardiac rehabilitation. So we have also demonstrated its benefits in cessation of tobacco use, which is a problem which can be used. We have demonstrated its effectiveness in small studies in diabetes and some small studies in reversal of atherosclerosis. I'm going to finish off by looking at some of the new things that can be done. That includes family-based interventions, task sharing and task shifting, and the role of telehealth in secondary prevention. In terms of post-MI patients, it's not that they have only cardiovascular risk factors, but they have multiple other conditions. And so we are looking at an intervention in terms of many other conditions outside of cardiovascular disease. For example, many patients have depression, and because of which they are non-compliant to drugs. Can we co-manage depression? They may have osteoarthritis, because of which they may be unable to exercise. Can we co-manage osteoarthritis and and cardiovascular diseases? These are the kind of things which we'll be doing in the future. One small point about family-based interventions. It's very difficult for individuals to live in a milieu which promotes atherosclerosis. If the family has a different diet, the individual cannot have a different diet. But this concept has not been tested very widely. So we conducted an open-label cluster randomized controlled trial among the families of individuals with coronary heart disease who had been diagnosed before the age of 55 years. And so we recruited 368 families with 825 participants in the intervention group and 382 families with 865 participants in the usual care group. In the intervention group, we provided a comprehensive package of intervention facilitated by non-physician healthcare workers for screening of cardiovascular risk factors, structured lifestyle interventions, linkage to a primary healthcare facility, and active follow-up for adherence. And we showed that over a 2-year follow-up, 1 and 2 year follow-up period, we wanted them to have any 3 of the 4, that the blood pressure should be reduced to less than 140/90, fasting blood sugar less than 100, LDL cholesterol less than 100, and abstinence from tobacco use. And as you can see here, the intervention care group had almost 2.25 times higher control of these factors. They achieved the primary endpoint 2.5 times higher than the control group. It's not going from 5 to 10%, but it's actually going from 40% to almost 65%. So clearly suggesting that we need to look at family-based intervention. Finally, telemedicine as an example, we have created interoperable platform that includes multiple technologies. It includes electronic clinical decision support system, an electronic stethoscope where a doctor sitting remotely can hear the cardiac and respiratory sounds, a point of care diagnostic device which can do multiple tests, a high definition camera, and an AI enabled ECG. And we have piloted it by in terms of providing assisted telemedicine in 2 centers in Tamil Nadu, and have been demonstrated it to be quite a big success. We also provide on-foot telemedicine assistance for people who are unable, particularly stroke patients, who are unable to come to the clinic. We go to their houses and provide telemedicine assistance. In addition, we are looking at providing, there is a group called HelpAge India, which provides assistance to elderly people. And we are planning to install our telemedicine solution in these vans and provide care. And in the future, we'll be able to create these kiosks, mobile kiosks, which can be carried in a small suitcase and can be set up anywhere and provide telemedicine assistance. So this is the dashboard. So it has it has training for the healthcare workers in terms of general physical examination and a template-based history. It can provide longitudinal trends for both vitals as well as lab, can provide AI report on the ECG, and provide electronic decision support for the management of several diseases, provides an e-prescription and history, markup for follow-up visit, and markup for reference. And this is the remotely heard cardiac sound in the stethoscope, which the doctor can direct to the health worker or the nurse to look at the patient. We have evaluated this and shown, I'm just showing you an example of reduction of blood pressure on follow-up, which is quite encouraging. In fact, there's a 6 millimeter drop in systolic blood pressure, as good as any clinical trial. A large number of patients have been seen, and particularly 20% of the elderly have been treated. A large majority of females have been treated, and we have impacted quite a few patients with NCDs. So I'll stop here. I had to, there are many other things that can be spoken of, but because of paucity of time, I just concentrated on these 3 or 4 aspects. I'll leave you with this quotes. This is by Toni Morrison, the African-American author from the US, who wrote the Song of Solomon, in which she said, if you don't create the future, the present extends itself, and which we do not want to. But also, I like the poem by Robert Frost, who said 2 roads diverged in a wood, and I took the less traveled by, and that has made all the difference. So if we have to improve secondary prevention, combat cardiovascular disease, we need to think out of the box. So thank you very much. I'll stop sharing now.